Hi, everyone. This is Amity Overall-Labe with NORC, and I'd like to welcome you to our final webinar of this four-part series titled COVID-19 and Ombudsman Programs, Understanding How Trauma Impacts You, Residents, and Your Advocacy. The focus of today's presentation is grief and mourning in a time of COVID-19. Dr. Sherry Gibson is our speaker today, as she has been for this entire series. Dr. Gibson received her PhD in clinical psychology with an emphasis in geropsychology from the University of Colorado, Colorado Springs, UCCS. She's an instructor and clinical supervisor for the psychology department at UCCS and a faculty affiliate with the UCCS Gerontology Center. Before I review some housekeeping details and resources, I want to say thank you for joining us today. We have had a record number of registrants for these webinars and have received an overwhelmingly positive response to this series. So thanks again to the Colorado Ombudsman Program for sponsoring this series and making Dr. Gibson's expertise available to our entire network. Next slide, please, Katie. So a few reminders. All attendees, I'm sure you've noticed by now, are muted. You may ask questions by using the chat or Q&A feature on your screen. When you have a question, you can jot it down anytime during the presentation in the chat box or Q&A feature. Both options are at the bottom of your screen if you scroll your mouse down. The webinar recording and materials will be posted on our website, and we'll send a link to all registrants once they're available. Next slide. I just wanted to touch on a couple resources. We do have some new folks that weren't here for the last webinar, but some of you may already be familiar with these. But the first one is the Taking Care of You resource. Oh, sorry, next slide, Katie. Thank you. The Taking Care of You resource, we cover compassion fatigue, burnout, individual trauma, and trauma-informed care, as well as typical reactions to stress, some self-care tips, and program management considerations. So we created this in hopes to help you take care of yourself, but also support your staff and volunteers. Next slide. These are the links to the NORC COVID information page. There's a lot of information on this web page, including updates from CMS, ACL, Consumer Voice, and some examples and advocacy from ombudsman programs across the country. And I also included the link to the ACL website with COVID-19 information. Next slide. There are a couple public pages on the Consumer Voice site as well. One page is specifically for information for advocates that includes fact sheets, webinars, and a map with state COVID nursing home policies and information. And then there is a separate page specifically for residents and families with some tips to stay connected, ideas for ways that they can get involved and take action and actually participate in some systems advocacy, and an option to share their story, either the resident or the family member, about their experience in a long-term care facility during COVID. So I wanted to share those links with you as well if you haven't seen that information already. And with that, I will turn it over to Dr. Gibson.
Thank you, Amity, and appreciate you having me here again this month. Want to also thank Leah McMahon with the Colorado State Ombudsman Program, and Katie, who has been such a wonderful help working all of the background details of these trainings. And lastly, I want to thank all of you out there on the call for your feedback every month as we've done this webinar series. It has greatly informed each training in hopes of crafting it, tailoring it to exactly what you need, what you want, what you're struggling around, to give you the tools, resources, education that you need to do the very best job that you can do during this remarkable time that we find ourselves in. I want to also thank everybody for the monthly calls that we've been on to get more information about where you are in your individual states and collectively how we can help support the Ombudsman program across our country. So thanks again, everyone, for being on this call. This is, as Amity said, the last of this webinar series, and it's a it's a little bit of a bittersweet process for me because I've really thoroughly have enjoyed the process, the learning that I have gained from getting to know many of you across the country. I have had calls from different states who have reached out for some consultation, and that's been really satisfying to me. So I hope that you all will continue to stay in touch as we move away from the series. So as we approach this last training, our topic is grief and mourning. And this is a really important topic that you all have identified and we agreed needed to be covered as we end this series. Some of the things I've been thinking about as I put together the information was I was reflecting on my own practice as a psychologist. And for those of you who are new to this call and may not know, I'm a geropsychologist. That's how I identify. I only work in geriatrics and I've only been trained in geriatrics. And I was reflecting on the first clinical rotation that I ever had as a graduate student. And I had to interview with the director there. And the director asked me a question in the interview and he said, "What do you think makes working with older adults in psychotherapy different from any other cohort of people? What makes them different?" Well, I started to regurgitate everything I'd learned in my textbooks and in my classes about aging and mental health and losses and, blah, 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 trying to impress my knowledge onto this director. And he said, actually, the thing that makes working with older adults very different and specific when compared to any younger cohort is that it is death. And it is that death is always on the mind of the client. Their death, their process around understanding the life review process or thinking about the days that are limited for them. And I found that to be, well, obviously quite a learning moment in my own interview process to think about, wow, I never really considered that older adults would be always thinking about death. But I can tell you these many years later, that is on the mind truly of every person that I work with in therapy. Every older adult is thinking at some level about their death and trying to make the most of the days left for them, trying to reconcile old wounds, trying to grieve over old losses, approaching new losses. And those losses are far-ranging. It's everything from death as we would know it, but then also the loss of independence or loss of one's idea of what this time of their life was supposed to be, especially faced with a medical illness or some kind of crisis. So loss and grief is very much a part of my clinical work. And I think it's important to share that with you. The other piece that I've been thinking about too is that prior to COVID, actually it was about a year ago, I did a community co-presentation with a colleague of mine who is in the philosophy department at our university here. We did a community presentation on death, dying, and the dead. And one of the things that we looked at in that presentation is our Western society, for the most part, has a real aversion to thinking about death. And Irvin Yalom, who is a psychologist, an existential psychologist, has a saying that while the physicality of death destroys us, the idea of death saves us. And one of the things I want you to be thinking about as we talk about grief and mourning, which is tied to death, is that when we have these moments where our immortality is brought right front and center, It is a moment of pure awakening for us, where we can do our own life review and we can think about priorities. We can think about what we want for ourselves and what we want for our families and our loved ones. So I'll be talking a little bit about that later on, but I wanted to share those initial thoughts with you. Katie, next slide. So COVID-19 has really been a tsunami of death. The pandemic has resulted in an enormous loss of life around the world, particularly also in the United States. The collateral damage that this level of mortality would exact on American families could not be overlooked. It's important that the burden of bereavement and its potential mental and physical health consequences is factored in to discussions around public health challenges that are facing all nations. Next slide. Certainly, as we are 6 months into this pandemic, we've noticed the negative consequences. And not only with this pandemic, but as we look back on other pandemics, such as Ebola, for example. But some of the specific consequences is that chronic social isolation and loneliness. And I've listed it at the top of this slide because that truly is something that we are all concerned about in long-term care. Crippling unemployment, financial insecurity has been another negative consequence. We've seen increases in domestic violence, child abuse, and elder abuse. Escalating sales of guns and alcohol. I read an early statistic when the pandemic first began, and I read that the sales of guns and alcohol were only second to toilet paper and sanitizer. We've also seen a rising in suicide rates and an exacerbation of mental health problems ranging from anxiety, phobias, depression, post-traumatic stress disorder, and attachment disorders. Next slide. So I want to poll the audience and ask you a few important questions. This is a question I'm interested to know in your work over these past months. Have you encountered residents, families, and or long-term care staff displaying significant distress over the following areas? And please check all that apply to you. The first being the possible loss of loved ones, though they are currently without symptoms of COVID-19. The possible loss of loved ones who are presenting with mild or moderate symptoms of COVID-19, the possible loss of loved ones who are presenting with severe or end-stage symptoms, the death of loved ones from COVID-19, and the death of loved ones from other causes with their distress exacerbated by the conditions of the pandemic. So I'll give us a few moments to log on to those polling questions or log your answer.
Sherry, Dr. Gibson, I don't think we have the polling questions, so if you can just write down your answer.
Oh.
Sorry about that. I don't think the polls were created.
Oh, I'm so sorry. Okay. Okay.
That's okay.
That's all right. I'm sorry,
I suggest
everybody.
either you can put it in the chat message or you can write it down on your own paper and then kind of keep track of your answers.
Okay.
Thank you. Sorry about that.
That's okay. And actually, I'll just say here that this is the only polling question. So I just wanted to get a sense, but I'm reading the chats as they're coming through. Looks like, yeah. So possible loss, but there are several people who are saying all of them. D, the death of a loved one is happening. Yeah. I'll just give you a few more minutes. Okay. So this is really important to understand what you all have been, managing and responding to in your work. And the enormity, I think, from your answers, and the significance of that is that all of you are at some level dealing with either your own personal grief or the grief response of other people. So I appreciate you logging on. I'm sorry I can't show you percentages. But Katie, I'll have you go ahead and switch to the next slide. I read an article, I believe it was in the New York Times, because I just jotted down some notes from it. But I want you to imagine this analogy that was presented in the article. The author said that imagine for a moment that 1,000 domestic passenger planes crashed in a few months' time, and that the country was jolted by a new airplane crash every few hours, day after day, for weeks. That analogy represents the massive loss of life, which at this moment in the United States exceeds over 150,000 people, that COVID-19 has inflicted on our country. But because so many of the virus's victims have died in quarantine and their funerals have been delayed or downsized, there have been very few visuals to illustrate that loss. I mean, this is one visual that I'm showing here now that gives you a sense of the dramatic effect this pandemic has had on our world. But without those photos and those stories of the dead to stir up our emotion, the pandemic has yet to spur the prominent collective displays of remembrance that typically mark national tragedy. When you think about the rituals that we are accustomed to in our society, we're entering a whole new realm of what we call e-mourning. We've had to change the way we ritualize the dead and the way we memorialize the dead. And there haven't been those large displays of remembrance that we would likely see if we had the analogy that I started out with the passenger planes going down day by day, week by week, hour by hour. Next slide, Katie. Contextually, COVID-19 puts a whole different frame on dying. Several aspects that make this unique is the shocking and unanticipated death. And really second to that is that isolation from family, from the dying and from their supporters. We've noticed high anxiety and feelings of helplessness that comes from the fragmentation of caregiving and attachment bonds, where family members could sit next to their loved one in an active dying stage, hold their hand, whisper to them, reassure them of moving on. Those things cannot exist. And the people who are doing that to their best of their ability are physicians and nurses and medical staff. This also inherent in the context of dying during COVID-19 is this existential crisis. The faith in a higher power begs the question of where is God now? And that is intimately tied to the loss of religious community and the importance of rituals, death rituals. There's a profound loss of meaning. The existential question, who am I and why am I here, becomes blurred and unboundaried in our thought process. We know that there's a disproportionate loss within minority communities and an overwhelmed medical system that is void of the family supporters who have always played a very vital, key role in care. We often focus, I think, and maybe over-focus on the impact that COVID has had, certainly on people who are ill, people who are dying, and their loved ones. But the impact on medical care providers who often turn to family to provide the emotional support or even the education about the patient, who no longer can do that or is very limited in how they can do that. Next slide, Katie. When we talk about grief, we have to talk about what is normal for grief. This is important because grief is a normal reaction to a loss. Grief reactions they vary depending on who we are, who we lost, our relationship to that person, the circumstances surrounding their passing, and how much their loss affects our day-to-day functioning. Different people express their grief very differently. You may even have a different grief response between one loss and another loss. And reactions to grief and loss include not just the emotional symptoms, but also the behavioral and physical symptoms. And those grief reactions change over time. All are normal within a short period of time. So, for example, the emotional symptoms that people often experience are shock, denial, numbness, sadness, anxiety, and guilt, fear, anger, and irritability. On the behavioral side, people experience unexpected crying, intermittent bouts of crying, coming on without any real reason at benign times. Changes in sleep patterns, not eating or no appetite, withdrawing from others, restlessness, and trouble with making decisions. And on the physical side, people often report problems with concentration during a grief reaction, exhaustion or fatigue, decreased energy and lethargy, maybe even memory problems, upset stomach, pain, and headaches. And on the abnormal side of that, there are other behaviors or physical symptoms such as using drugs and alcohol or increase in violence, suicidality. And in those situations, those often do warrant reaching out for professional help and getting an intervention started sooner than later. The duration of those symptoms varies from person to person because, as I said, we all experience grief and deal with grief in a different way. But the research shows that on average, a recovery time in terms of normal grief is between 18 to 24 months. So a maximum usually of 2 years. And grief reactions, as most of you know, are often stronger around significant dates such as death anniversaries, birthdays, and holidays. Those can be especially difficult times. Next slide. Now, on the other end of that spectrum, I'd say from normal grief is something we call prolonged grief. The International Statistical Classification of Diseases and Related Health Disorders, which is the medical classification list for the World Health Organization, it's called the ICD-10. They have a list of criteria. There is a disorder called prolonged grief disorder. And the criteria I have listed here, well, first and foremost, it involves the death of a close person. It is a persistent and pervasive grief response that is accompanied by a longing and a yearning or a preoccupation with the deceased. Often combined with that is an intense emotional pain. All of those things that I listed earlier, the sadness, the guilt, a loss of sense of self, absence of positive mood, numbness. This type of response lasts for a minimum of 6 months following the death, but that also exceeds any social, cultural, or religious norms. So for some religious sects or for some traditions and cultures, there is a normative time after the death of somebody where it's expected that the person would grieve for a certain amount of time based on that culture or on that norm. So this goes beyond that. When you take away the cultural piece, the tradition, the religious piece, then 6 months after that as a minimum, where these things are also happening, is what we would consider prolonged grief. And the last piece of this, which I think is really the most important piece, is that the person experienced significant impairment in personal, familial, social, occupational, and other functioning. So this is the person who can't keep their job because of the grief, who is maybe having a hard time parenting their children, is having a hard time maintaining important relationships because of the grief. And it's really that impairment in those areas that warrants us looking at it more from a diagnostic framework as opposed to a normal grief response. Next slide. There are negative impacts from prolonged grief, and it's both physical and psychological. When we control for other known causes, what we have found, what the literature has found, is that prolonged grief is associated with certain disorders such as myocardial infarction and congestive heart failure, immune system dysfunction, substance use and abuse, essential hypertension, impairment in functioning, a reduced quality of life, and increased suicide attempts. Next slide. There are also some additional risk factors for prolonged grief disorder, meaning that people who have these other things on top of a death or a grief reaction are much more vulnerable to having a prolonged grief disorder. So that is social isolation. Interesting to think about social isolation in the context of COVID-19, which we know is rampant right now, that there are many people who are socially isolated just by virtue of the pandemic and the quarantine measures. The suddenness of the death, also important in the context of COVID-19. People who have an insecure or anxious attachment style, a spiritual struggle with the death, inability to make sense of the loss. Also, a risk factor is lower education or lower socioeconomic status, and lack of institutional or information support. When I look at this list, and I don't know if you're doing the same thing right now, but when I look at that list and I match that up to where we are with COVID, you can't help but think what might be on the horizon for us as we, as a nation, as a people, as a society, deal with and grapple with the enormity of the loss that our world has suffered, and how much of that prolonged grief disorder might come up in the people that we're serving, people that we're in contact with, and that we're intervening with. It may also be for us. And so thinking about our own reactions and how we're dealing with grief, and as you re-enter into long-term care facilities, and I'll talk about that a little bit later on here, but that also being aware of your prolonged grief response as you start to see it firsthand. Next slide. I think that this is certainly a public health crisis that we're in front of. We are all having to grieve in isolation for the most part. The spike in COVID-19 related prolonged and complicated grief is really a potential public health crisis. There's an urgency in the need for timely access of mental health services. And I can tell you in my own practice, and I met with another therapist earlier this morning, we're having to turn away clients, and there isn't enough therapists to go around right now. We really are in the middle, or we are embarking on a mental health tsunami too. This can also be seen, though, as an opportunity for all of us to think creatively about bereavement efforts. We have learned from past epidemics, Ebola in Congo, for example, and we are seeing that there is some that creativity that is coming up, such as live streaming of funerals, physicians and chaplains using either the speaker function on a phone or video chat function to allow families to be able to say goodbye to a critically ill loved one and to deliver last rites to a patient. This is what we're calling a new era of maybe e-mourning, something that we're all having to do from a distance yet connected through technology. And this grieving in isolation, it's kind of interesting. It's somewhat of an oxymoron, isn't it? Especially in many cultures where mourning is that shared social practice. We heal when we are together. When we are in community, we heal. And we're now forced to think of community and healing in a very different way. Next slide. You may have heard this term before, the good death. The good death prior to COVID-19 was characterized, and this came about by surveys of patients and families. What is the good death? What does that mean? Of course, that's going to be very individualized, but the factors that come out in that is adequate pain management, being accompanied by somebody, a loved one particularly, at the time of death, exercising choice over location of where you're going to die and the circumstances around your death, being able to determine who will be present at the time of death, and having time and space to say goodbye, to have important conversations, feelings of not being a burden to others, and leaving behind a meaningful legacy. All of these have been associated with the good death. And the notion of a good death in the context of COVID-19 really has seemed nearly impossible when you think about these factors and where we are right now. Especially when we've seen images of makeshift morgues in the streets, inundated ICUs, refrigerator trucks that are parked outside of long-term care facilities or hospitals. It butts up against everything that we have understood as the good death. And we know that many people might be dying a bad death. Next slide. So we have to rethink what is a good death in a time of crisis. We know that many people have died a bad death, given that those factors that I listed have been associated with a good death. You can see the inverse just by virtue of dying in a pandemic would then infer that these were bad deaths. And yet, psychologically, we have to accept the fact that that is going to happen, and that has happened. Understanding the bad death provides, I think, a rich opportunity for all of us to redefine what might be a good death during a pandemic. And I think it also increases our recognition of the importance of end-of-life care and bereavement support. Now that we've been through this, we're going through it, how can we do better at bereavement services? What do we need to do differently around end-of-life care? Finding unconventional ways of mourning could result in an expansion of palliative care, chaplaincy services, social work services. We could have, in this moment, our own moment of awakening at how to do it better. Next slide. So I want to lean in for a minute, all of you. And as I've been talking, I want you to just get in touch with what you're feeling right now around this topic. What comes up for you in this moment as you imagine re-entry into a long-term care community? how will you cope with your own grief response and sitting in mourning with others? One of the things that I've learned from all of you is that you've advocated for residents and families, and you're often not told whether or not a resident has died. And so as you go into facilities again, as you start that process, you may find that several of the residents that you've helped have since deceased. You may have a tremendous sense of loss as you walk into a facility. It could be loss of staff, it could be loss of residents, it could be loss of what you thought was a normative situation or a process of operating, and that loss of what you assumed to be happening you could be confronted with. And as one of my friends and colleagues brought up in one of our conversations about reentry, she said to me, what will people feel like when they're walking away from the facility to their car? And when they sit in their car and feel that pressure or that sense of sadness come over them. Because as ombudsman, what I've learned is that you have a very isolative, in some respects, practice. You're very much on your own. When you go into these facilities, when you work with them, you're supported on the outside quite a bit. But a lot of your work is done in isolation. So how will you grapple with that? How will you acknowledge the feelings that come up, the experience that comes up, and what will you do with that? One of the things that our society struggles with is our anxiety around death. We don't want to think about it. And as I mentioned earlier, Irv Yalom, the psychiatrist who I have followed, as he's kind of the godfather of existential psychology, he's written a book called Staring at the Sun. And he titled that book for a very good reason, that looking at death, looking at our own death particularly, is like staring at the sun. We can only do it for a few moments before it becomes too dangerous, too scary. And so it's important for you all to think about death and dying at this moment, and what is your reaction to that? And thinking about it can give you moments of awakening. When we stuff it down, when we don't think about that, that's when we suppress, and when it pops up unexpectedly if we haven't dealt with it. But you can't stay there for long. You have to get yourself out of it eventually so that you can do your work, so that you can be less anxious. Next slide. You have to find time to give yourself the space to grieve. It's normal and important to express your grief and to work through the concerns that arise for you at this time. Avoiding your feelings may not be helpful, and it may delay or prolong your grief. So a couple of suggestions I've listed here for you to consider is, one, you want to find supportive people to reach out during your grief. And remember, grief isn't just around death. Grief is around all kinds of loss. The loss of the world that we assumed to be normal is no longer normal. The loss of the way our lives are structured now, the communities that we've been involved in. Maybe it's the loss of your children not returning to school, the loss of the way you have operated day-to-day life, and now you've got to rethink all of that again. You've got to take care of your health. Often at a time of loss, we stop doing the things we need to for our own health care, such as exercising, eating correctly, or taking our prescribed medications. If you are on a healthcare regimen before COVID, it's important to come back to that plan. making adjustments in the context of limited access and physical distancing. I don't know about you, but in the beginning, I got off my plan. I stopped going to yoga, obviously, because yoga was canceled. Couldn't go to the gym. But I could, pick up a gallon of ice cream at this grocery store. That was still within my reach. What I noticed, though, is that as time has gone by, this is no longer a temporary situation. This is a long-term situation. So I've had to recalibrate and get back to what I was doing before and figuring out creative ways to get myself back on a new type of healthcare plan. Whenever we are grieving, it's really important to postpone any major life changes. Give yourself time to adjust to whatever loss it is that you're going through right now. And this is something that I'd recommend you talk to with the clients that you're serving, your residents or families. People need to take the time before making really important decisions. Could be changing jobs, moving or selling your home, remarrying, those kinds of things. Grief sometimes clouds our judgment and ability to make sound decisions. You also want to find a way to participate in activity. Staying active through exercise, enjoyable activities, outings with support of others, starting new hobbies can help to get you through these tough times while providing opportunities for constructive development and use of your energy. I skipped one. Consider keeping a journal. Journaling is often very helpful for a lot of people. It's a method by which you can work through your feelings, write or tell a story about your loss and what it means to you. I recently just started journaling myself because I was feeling a profound sense of heaviness, I guess. I noticed one day that I'd seen 7 clients in my office, and every single client had been sobbing on my couch. And it was so much that it really struck me. And I needed a way to process it. I needed a way to talk through it with myself. And so I started journaling, and it's been quite effective. And I'd recommend it to you too. Also, finding a way to memorialize ones who have died. When you re-enter into long-term care communities and you've lost residents with whom or for whom you've advocated, you want to find ways to honor that person's life and the work you've done with them. And it could be anything from setting a balloon off, or planting a tree, or taking time in the garden in the name of a loved one or a special person that you have lost. Dedicating some kind of work that you do to their memory, or even contributing to a charity in their name. These kinds of activities can be very helpful. And lastly, you might want to consider or offer the consideration to those that you're working with to join a grief support group of some sort. Now, of course, this is all happening online for the most part, but remember that depressive symptoms, such as feeling sad, are a fundamental part of normal bereavement. Staying active and finding support from others can really help you work through that grief process. And I'd also recommend utilizing your employee assistant program benefits. That can be extremely helpful too. Next slide. I want to share with you a poem that was written by Dr. Robert Neimeyer. Dr. Neimeyer is associated with the Portland Institute, who specializes in grieving and mourning. I've actually included their link in the resources page for you. because I really recommend that you look at what they offer. They have they have webinar trainings, they have resources, they do a lot of research, and I've attended some of his webinars on grief and bereavement during COVID. But he's also a poet and he's an artist, and he wrote a poem called Old Shoes that I want to share with you. He says, "I'm wearing old shoes and will for a while yet, standing into surrogate connection to a world at social distance, the grief still holding close. Sometimes when the longing for a single living thing overcomes me like a sudden hunger, I shuffle from the black mirror to the long grass, painted in dew, and jerk the mower into a sputtering roar as I walk the tight lines, feet slipping in the mud, just to smell the grass, remove it in clots from the black bag and hold it just a moment more like memories before releasing it to compost." Next slide. Loss is multifaceted, and so is grief. There is no one size fits all, and my process will be very different from your process, and so on. I hope you will give yourself and those that you're in connection with, whether it's through your work or personally, permission to bereave the loss and hold no expectation for the duration of how it should look and how it should feel. Understand for yourself that there's going to be anxiety, particularly around your work and as you start to re-enter into long-term care facilities and communities. And know that what you're feeling is normal. The anxiety is normal. And the work also has to be done. So addressing your grief, maybe going back to all of the other webinars that have been presented by me during this time, going back to those tools and reminding yourself of what you could use in this moment to make this a better moment, what you could do, what you could say to somebody else to communicate empathy and understanding. To understand too that this is a problem that we can't fix maybe, but we can do as much as possible. Remember the parable of the hummingbird. You're doing all that you can. Those are the things that we all need permission to do right now. Whenever I feel anxious, and I don't know about you, but I've woken up a couple of times in the middle of the night with my fist clenched and a knot in my chest and a feeling of dread that I can't really put my finger on, but it's there. That when you have those moments, to remind yourself, hey, I've never lived through a pandemic. I don't even know what this is going to be like. Giving ourselves grace and forgiveness and others grace and forgiveness during a time where we're all going to act a little not normal, shall I say. We're going to do things that are not like our normal selves because we're living in an abnormal time. If you could switch the slide, please. I've given you a couple of resources here. The Portland Institute for Loss and Transition is what I've mentioned before. Dr. Neimeyer, whose poem I read, he's very involved in this effort. I've also given you a couple of resources that I read in putting this together. And next slide. And of course, I want to thank the Colorado Ombudsman program in my home state and thank all of you across the nation in the work that you're doing. I know that we are way before the end of our time, and I did that on purpose because since this is our last webinar, I thought it would be a good idea for us to have some time together in terms of you asking some questions and maybe having a little bit of dialogue between us on any of the webinars that you've attended, any questions that come up. Either myself can answer, or Amity or Leah. We'd all be happy to have that kind of dialogue with you. So please stay on, and Amity, I'll let you look through the questions if there are any, and we can have a conversation.
Thank you, Dr. Gibson. Let's go to questions. Katie, if you can just go to the slide with the keyboard. I'd like to remind folks how to enter your questions. You may be taking a moment like me to just breathe and take in everything we just heard and mull a little bit. So feel free to send in what you have. And for now, Dr. Gibson, we had a question about what about the impacts of COVID on other losses such as funerals for those who die from other things that were canceled due to COVID? Mm-hmm. And I think you spoke to that a little bit already.
I'm not sure what part of that, how to support families through that, or what particularly, maybe I'm missing the question. We're certainly doing it differently.
Sure either.
Okay. Well, we're certainly doing it differently. Whether it's COVID related or not, funerals by and large are having to be done. And I think it depends certainly on the state where you're living, and it depends on the funeral home too. I have seen different practices in my own state. There are funeral homes who are allowing for funerals, but they're keeping it to a certain number of people who can attend. There are other homes that are not allowing in-person participation and who are filming it like on a webinar basically, so that people can log on and they can watch the service. I've seen a few veteran services that have been done where they do the full taps and the folding of the flag, but of course nobody is there and they're watching online. So I think it really depends on the state, the city maybe, and even maybe it's down to the funeral home and what they're comfortable with doing.
Well, and you may have already mentioned this, so I apologize if I missed it, but I seem to recall it may have just been a story floating around about a woman that lost her mother, and she was a resident of a long-term care facility. And it wasn't a funeral, but a memorial service. And it was kind of for lack of a better word, almost a drive-through memorial service to where the daughter stood outside and the cars drove by and got to share some thoughts and give her flowers, etc. So another way to physically distance yourself, but be able to communicate directly with those that are impacted.
Yeah. That's a great example. Mm-hmm.
So, and this is a really good question, and I think the person that asked this question hits on what you mentioned earlier about what we may see potentially in a public health crisis going forward. But can something trigger grief related to loss years later than when the loss happened, and is that normal?
Yes, it is quite normal. Absolutely. There are cumulative losses that occur. And for example, I was working recently with a woman who's in her 80s, and her father died. And when her father died, she also was reminded of other deaths that have come up. And so she collectively mourned all the prior deaths as well. And one of the things that she struggled with in her father's death was that he wasn't a good dad. He was quite abusive towards her. And in his death, she started having nightmares about him. And what we identified through her dreams and the nightmares were that she was attaching his death to all the other prior deaths in her life. And she was being visited in her dreams by other people who had died. And she was feeling that kind of pressure the burden of the grief by all the other deaths that was triggered by the most recent death. So I think that that is a very normal response. We know that that's a normal response. It's not just that I think it, we know that for sure. And it could be, I've had the experience myself where I've attended the funeral of an acquaintance, nobody that was really that close to me, but in sitting in the funeral, I find myself sobbing and thinking about the death of other people that have been very close to me. And so, yes, when we have something that comes up for us, we may be triggered by all the other prior deaths, and that can also complicate our grief process.
Thank you.
Mm-hmm.
And this is a shorter answer, I think, but it says that many of the manifestations of grief that you listed pertains to most age groups, not just the elderly. Is that correct?
Oh, yeah, absolutely.
Yeah.
No, this is something that's shared throughout the lifespan. Absolutely. Mm-hmm. Yeah.
Thank you.
You bet.
Do you have any specific resource recommendations for someone who is suffering from the loss of a relationship where the loss isn't due to death? For example, the loss of a relationship with a significant other.
Right. Again, yeah, I would really recommend that person go to the Portland Institute website that I showed you, because they handle loss and grief for all different kinds of losses. And I think too, there are, the wonderful thing about age of technology is you can Google just about anything and find anything. But I have found that the Portland Institute on Grief and Transition is really a terrific resource. They have also listed on there other resources that you can go for additional information. So I point that person in that direction.
Thank you. I'm scrolling, so just
Sure.
1 second. Good question. I think a lot of folks are experiencing this one too. And you did speak to a little bit about how a lot of us are experiencing grief alone, or at least in some capacity, definitely distanced from others. So is insulation the same as coping? Sometimes I find I'm looking for ways to insulate myself from the emotions that are just so overwhelming just to cope and basically get by. What do you think about that?
Oh, that's tricky. Insulating oneself is protective, and I get that. It is protective, and at the same time, we know that some of the best ways to manage our grief is through talking and sharing. So what I would recommend to this person is that you find a way to express your grief in a way that feels safe to you. Because keeping it all to yourself, while that might be protective, and maybe we do that for a myriad of reasons. One might be that we don't want to burden somebody else with the heaviness of our grief. And so we keep it insulated. The problem with that is that we're typically not our best therapists to ourselves, because we have very biased and sometimes negative narratives about how we're dealing with things, about how we see things. And it really does help to be able to talk to somebody else who isn't burdened by it, who can give you an objective perspective, or maybe even just validate it and sit with you in it. Sometimes when we keep it to ourselves, we may not fully how do I want to resolve it, I guess. We may not fully resolve the grief. Now, if you don't feel that there's no safe space for that, the next thing I would recommend is journaling, because what journaling does is it gets it out of your head and onto paper. And that process actually helps in terms of your own healing. Remember when we talked about trauma early on, is that trauma, and for some people, grief is traumatic, depending on the nature of the circumstances or the death that occurred. It can be traumatic. And those are held way deep in our midbrains. one way to get it out of the midbrain in order to bring it forward for healing is, one, to speak it, and two, to write it. So if you can't speak it, I recommend writing it.
Thank you. So we actually were discussing this issue before we went live with the webinar between Leah and Dr. Gibson and I about the possibility of yet another shutdown. And so this comment speaks to that a bit. I'm not sure we have any answers, but we can try. The commenter says, we've been conducting outdoor visits with residents in Illinois. Residents are expressing a fear of returning to the restrictions as cases spike in states around us. Many residents state that mentally they cannot go back to how things were when they first started the restrictions and the lockdowns. One commented that she would even commit suicide if she had to go back. How do you approach that and provide comfort when we have no idea what to expect?
Right. I would, and this is something that I've been faced with also in my practice, working with families, with residents who've been quarantined, some of their own fears about that. I think, one, always validate and reflect back the anxiety and the fear that is there. Normalize it for the person. It makes sense why you would not want to go back to that. And that, that when we are focused on the what ifs of the future, that is essentially anxiety. Anxiety is about the things that haven't happened. We don't know if it'll happen, but I'm worried that it's going to happen. And what if it does happen? That is quintessential anxiety. I would come back to, and what I've been doing after I've normalized that, I've reflected the feeling back to the person, I validated how they feel. I then go into that, remember the FACE acronym that we used in the last training on anxiety? And that FACE acronym was: focus on what's in your control right now, acknowledge how you feel, come back into your body. So get yourself active in something that you can do, and then fully engage fully in whatever activity it is that you're doing. It's very difficult to sit in that kind of anxiety with a person when we can't fix it, we can't know. And when a person expresses that they want to kill themselves, this is where I would focus on their strengths. What got you through this first round? How did you manage that? And really highlighting the goodness, that the good things that they did, or whatever it was that they did. And recognizing that we're all in it together, and that I will support you through if this does happen again. But we can't guarantee to any person that it isn't going to happen, obviously. And if a person talks about, I would just commit suicide, you want to explore that further, or you want to let the social worker know this person is, talking about suicidality. They need to be able to talk through this with a therapist. Is there somebody in behavioral health that they could talk to? So getting them the therapeutic resources so that they can talk through, and so that somebody who is who understands that professionally can assess them for risk. That's something that, of course, I do and other psychologists do, or any mental health professional. And that's something you want to take seriously, because suicide in long-term care often takes a more passive role, where the person stops eating, stops taking their medications, refuses medications. It looks more passive. But you want to get them, if people are talking in that way, you want to get them hooked up with some kind of mental health service that they can really talk about that, get some support. But those things that I just mentioned are things that you all can do in the moment with them.
Thanks, Dr. Gibson. And I know the commenter, being from Illinois, is probably aware of this resource, but I want to share it with everybody else in case you're not. And I will see if we can put it in a link under the webinar recording since this is such an important topic. But months ago, maybe a year ago, I'm completely losing track of time at this point, we did a webinar with talking about mental health support for residents, including how Ombudsman can respond when a resident says that they want to commit suicide.
Great.
And Illinois specifically created policies and procedures for their Ombudsman program, a script, for a lack of a better word, with questions that you can ask. And then, of course, there's reminders about Ombudsman advocacy, of course, is always resident directed, and there's confidentiality. So that is an excellent resource, and we can send a link to that and that webinar as well for additional help, because unfortunately you may hear more of these kind of comments, especially as you start to go back into facilities.
And the chronicity of that can't be minimized. The chronicity of the quarantine, and then also going back, and potential of going back into quarantine and isolation. And, you know, one of the things that I've been also hearing a lot more from my clients and families of residents in long-term care is an enormous amount of guilt that people are feeling, particularly around, you know, when their loved one was admitted into long-term care just prior to COVID, and now they have guilt about the life that person is having to live inside of quarantine, that is compounded potentially on the guilt that they were already feeling about not being able to care for the person themselves. So this gets very complicated, and I think we are going to hear more of that as time goes on too. So arming yourself with resources, knowing where to direct people, that's having that in your arsenal is really important.
And then another, not really a question, but I do want to bring it up. And I know that I think we talked about this in a previous webinar too, or maybe just our side conversations about long-term care facilities. Some are better than others as far as acknowledging when a resident passes away, but some still feel that they're afraid to talk about death because they don't want residents to get more depressed. But I think we all know in our experience that residents want to know and should know if their roommate or table mate or someone just disappeared one day and they don't have that opportunity to say goodbye, mourn, have any remarks. So this could be an area actually that Ombudsman programs could work on, with sharing best practices and how facilities can recognize and honor the passing of residents. There's a lot of solid examples on our website, I think under the culture change page or in individualized care. So just wanted to bring that up too. And of course, if you know of any practices, then share them with us. But just wanted to bring that up because a commenter added that in the chat.
Yeah, that's great.
So one more, and I believe we touched on this a bit too in previous webinars, but so if you didn't listen to this, then you may want to go back and listen to the anxiety one, I believe. But the question is in regards to anger. During all of COVID, I've had a large amount of frustration and anger directed at people who are not taking COVID seriously enough and the negative impacts it's having on residents. So what advice can you give on how to handle anger or frustration? And can anger actually be part of grieving?
Oh, yeah. Absolutely. Anger is part of grieving. And I think I've said this before, but anger really stems from fear. And so when I see that people are angry, one of the questions I ask them is, can you identify what scares you most? Because it's usually fear-based. And if the person can tell you what they're afraid of, then you can explore that more with them. You know, anger has really good, can have good outcomes for some people, because anger moves us into change. If we're not having that emotional reaction to an injustice or something of that nature, then, you know, we can we can move towards change. The problem, though, around the anger with people not taking, for example, wearing masks seriously. I have anger. Anger comes up a lot in my private practice with my clients, particularly around that issue. And one of the things that I try to remind people is that we can never control the behavior of other people. All I can do is control my own behavior. Now, anger and lashing out at people who aren't behaving or conforming in the ways that they need to in order to protect the health and safety of others, addressing that could have negative consequences for you and your own safety. And so what I encourage people to do is to take care of their own health, to put your health front and center and control your own behavior, because that's all we can control. We can't control the behavior of the other people. And yes, it may cause us to be angry, but expressing that anger could have also negative consequences. I have a client, for example, who has a history of being on a ventilator. She suffered sepsis at a young age and had a stroke and was on a ventilator for quite a while. And she's been very triggered by the current pandemic and the threat of having to be on a ventilator again should she catch COVID. So she's taken the quarantine very seriously. But one day she decided to go out to a convenience store to get a candy bar. It was one of the first times she'd been out in public. And she planned it very cautiously. She looked in the window and she saw nobody was in there except one other patron. She went in. The patron was taking too long. And by the time she got up to the counter, 6 or 8 people had filed into the convenience store, which, as you know, these are usually smaller spaces. Not one person was wearing a mask. And this was prior to our state mandating mask wearing for all public spaces. And she got very angry. And she said out loud, well, it looks like nobody here has ever been on a ventilator. Well, you can imagine there was one gentleman in that crowd who didn't take very good to her comment and confronted her. And it bubbled up between them and she ended up getting out of the situation. But it was, a realization that we have to be careful with our anger because it may be harmful to us or to others around us. So we can only control our own behavior and know that if we are in a place where people aren't wearing masks, yes, we may be angry and irritable about that, but we need to get ourselves to safety and do what's right for our own personal health and letting people feel empowered in their own personal health choices. I think that's where we get around the anger, or how we address it anyway.
Thank you. So several attendees have commented again about the overwhelming feeling of helplessness still, simply not being able to help family members that want to see their loved ones, not being able to see residents and help them, and how to cope with that. So before I pass it to Dr. Gibson, I don't know if you attended the previous webinars, but I'd say definitely go back and look at the compassion fatigue webinar. I think you'd find that helpful. And then similar to what Dr. Gibson just shared, obviously about not being able to control the actions of others. Personally, what helped me as a local ombudsman pre-COVID many years ago is I would keep a folder, both email and physical folder, of anything that went well. Anytime that anyone told me thank you, anytime there was a happy ending to a case that I wanted to remind myself of. And so similar to trying to remind yourself that you can't control the actions of others, I'd encourage you right now during COVID, maybe even make it a daily practice at the end of each day of your very, very long work days these days, and write down something that you know made a difference. Keep those nuggets on a list in a folder or something that you can refer to remind you that even though you may feel helpless, you're still helpful and you're still making a difference. So with that, pass that to Dr. Gibson.
Amity, that's a wonderful, wonderful reminder to everybody, me included. And one of the things that in my journaling, and I've often recommended this to my clients in their journaling, is to keep a gratitude journal. So at the end of each day, you write 3 things that you're grateful for. And it helps you focus on the things that are working in your life rather than focusing on the things that aren't working. And I think too, what you describe, Amity, is something that I've done for a couple of years now, is I keep what I call a kudos file. And this is a file of any notes or cards that I've gotten over the years from either colleagues or clients. I keep those things in a particular file so that when I'm feeling either helpless or inept or incompetent, all those things that come up, I look through that file and remind myself that, you know, I've done some good things, or that people have appreciated my efforts over the years. And that is a good reminder, because sometimes we can get into a unhelpful cognitive frame that just doesn't serve us well. And I get it, because I do it quite often myself. I don't know about any of you out there, but I'm continually plagued with the imposter syndrome. And it's been something that I have dealt with my whole career, always feeling like, you know, somebody's going to find me out anytime now. And at what point am I ever going to feel masterful at what I do? And I just think that for some of us, that's just an infliction. And so I have to remind myself, either through my kudos file or talking with people who are my closest friends who know my work, and just, you know, getting those reassurances, especially in the isolative work that we do. And sometimes we can't get that from our spouse, or we can't get it from the kids because they don't really understand what we do. I mean, whenever I talk to my husband about psychological stuff, you know, I can just see him glazing over. He's an engineer. And so I'm not going to get the, you know, he always says like, oh, you'll do fine. You always do fine. Well, that's really not what I need to hear. So anyway, those are some really good, helpful hints. The other thing I would say is I really like reading. I'm an avid reader, and a couple of things that you could read if you haven't ever read it. Viktor Frankl's Man's Search for Meaning is an incredible story and reminds us of the resilience that we have to actually have a strength or to get through a horrible thing. And that is a book that I've referred to clients. I've used it myself. Another really good book, who now I can't remember the title, but was written by Christopher Reeves. You may all remember Christopher Reeves as Superman, who you know, suffered an accident on his horse, became paraplegic, and maybe it was quadriplegic actually. Anyway, he's written a memoir about what he went through. And how he was resilient and strong through that. And I think those are important things to read, to remind ourselves of what we're capable of, and that there is hope, even in times of hopelessness. There's a saying that the lotus grows from mud. And that's a beautiful analogy of how beautiful things, how creative things, how extraordinary things can come from adversity. So if we can look back on this time and again, ask ourselves, how did I handle it? How did I get through it? Use this as your moment of strength rather than the moment of discouragement. Sit in and maybe relax into, I'm just going to use the advice that somebody else told me, relax into the moment. Let this be your moment to really shine in what you do, make a difference in what you do, rather than feel burdened by the suffering of so much.
Thank you. And on the similar vein, maybe help someone else. I know that if you feel like you're not helping residents, which I know you are, it's just not in the same way that you used to. Help your coworker, reach out to them, contact your supervisor, you know, send nice notes to people that are struggling just like you are. Working parents that are taking care of their kids for the umpteenth month and have no school in sight. You know, send nice notes, do things like that too. Think it'll bring some light and hope in a hard time. So one last question, and then I want to go to our closing slides. Let's see. And again, no easy answers, but I'm going to toss this one to Dr. Gibson for sure. What words can we use when talking to family members of those that have passed? I find myself at a complete loss.
Mm-hmm. It does feel hard, I think, for all of us to find the best way to respond to another person's loss. And for me, I think what I say is, first, thank you for letting me know that this person had died. And sometimes I like to share a story of the work or an interaction that I had with that person. For example, your mom and I had some wonderful talks, and I might actually share something that that person might have said about that family member if I have a story. You know, she told me about the time that you took her on a trip and you had this wonderful thing that happened. I might share something like that. And I find that people, when I've talked to families of clients who I've lost, when I share something like that, that's not breaching confidentiality, but is, a story, it makes them feel connected, and I feel connected to them through that person. So one, thanking them for letting you know, saying, gosh, I'm really going to miss that person too, and I know you are. And let me tell you about something this person said about you, or something this person shared, or an interaction that I had, or how much I enjoyed working with that person. I think that those are ways that we memorialize that person, and a way that we connect with the mourning family. You can't make it better. You can't sugarcoat it or silver line it, any of those things. And I think what you can do is just join with them. Join with them and maybe share something that was meaningful about that person in your work with them. I always think that goes a long way.
Thank you. And I want to share one last comment, not a question, and then we'll go to the last slides because I think it's helpful. I know, Dr. Gibson, you've mentioned a few times throughout the series about the importance of reframing in order to help you cope. So this comment was, I recently learned of the passing of a resident who I enjoyed conversing with and listening to her talk of her childhood life. As I began to feel the pain of loss, I allowed myself to shed tears, but later began to think of how she longed to get out of her bed but could not. Thinking about this longing she had allowed me to better deal with her passing. She had no family except for a nurse to whom she was not closely associated. As an ombudsman, I've had to learn how to deal with losing many residents within the past year that I was extremely fond of. So I just thought that was a really helpful comment to not dismiss the pain of the loss and not, negate the loss of that person, but to help you deal with those hard feelings. So thank you for sharing that personal story.
Yeah, thank you.
Okay, so lots of great questions and comments. Thank you so much. I want to move to our next slide, please, Katie. Thank you. So wanted to let you know of some things that we have coming up in the next few weeks that hopefully you'll check your inbox, and then if you're not receiving emails from us, I'll show you how you can do that in the next slide. But we've been working with some state and local ombudsmen to develop recovery and reentry resources as states start to reopen and ombudsman programs start to visit again. Most of those visits, obviously right now, if they are happening, are usually just outside. But these resources will help you think about safety, visits, even documentation, how to document visits and complaints. So those will be coming out shortly. Keep your eye on your inbox for those. We're also in the process, we don't have a title yet. It's very beginning stages of brainstorming, but we'd like to pull together a webinar about crisis communication, both hopefully trying to give you some tools in responding to those hard phone calls you're getting from family members and residents, as well as even working with the media, because I don't know about you all, but we've been receiving nonstop emails and calls from the press. So some Media 101 work for all Ombudsman program representatives. And last but not least, we are very excited. We are working right now with Dr. Gibson on creating another 4-part training series, but with 3 different audiences in mind. And so these are going to be 30-minute pre-recorded trainings that will live on the NORC and Consumer Voice website, walking through person-centered care, person-centered thinking, trauma-informed care, compassion fatigue, and grief and anxiety. And those audiences are, one will be tailored for family members, one for direct care staff, and one for long-term care facility administrators. So I've seen a lot of comments throughout these webinars about issues that family members, of course, are experiencing. So hopefully this will give you a tool that you can direct those family members to, as well as training for direct care staff and those administrators. So very excited to work with Dr. Gibson on that. We are recording them this month and next month, and we will start rolling them out week by week in September. So again, stay tuned for that, and we will send out a lot of promotional information for that soon. Next slide, please. So if you do not receive our emails, please join our database. There's a link on this slide. You can ask to join. You'll get webinar notifications, notification of new resources that we create. You'll also be part of the listserv to get our quarterly e-newsletter called the Ombudsman Outlook, and the NORC Notes, which is a monthly resource reminder of what we have available at the center and how you can use them in your program and in your advocacy. Next slide, please. So thank you again, Dr. Gibson, for another excellent presentation and for guiding us through this entire series and conversation. Another huge thank you to the Colorado Ombudsman Program for sponsoring this series. Thank you, Katie, for working your magic behind the scenes on all of these webinars. We really appreciate it and know it's not easy. We hope you all found today's webinar helpful and this entire series helpful. Continue to take care of yourself in order to take care of others during this incredibly challenging time. As a reminder, these slides and recording will be available on the website soon, and we'll send that link out to all of you. Please take a few minutes to complete the evaluation that pops up after we close the webinar. We really do use your feedback to shape and develop resources and training. So thank you all for joining us. Please continue to reach out to NORC if you need assistance. All right, that's it for today.
Thanks, everybody.
Thank you all. Take care.